And now, morning, everybody.
Morning.
February 7th. You're at the House Healthcare Committee, the morning session. And this morning, we're going to talk about H 233, an act relating to the pharmacy benefit management and the Medicaid wholesale drug distribution. And we're going to have legislative counsel go over the piece of legislation that we passed earlier. And then we'll get into Act 31.
Good morning, Jennifer Kirby, Office of Legislative Counsel. When we had looked at this issue last year, I put together a summary of Act 131 of 2022, which was the legislation that some of you had worked on a couple of years ago. So I'm just going to put that up and we can go through that again because I think it summarizes things well, but we may need to look at specific provisions of the language as we go forward. All right, so that is showing. So overview of Act 131, which was an act relating to pharmacy benefit management. And I think there we go. So the first two sections of the bill first expressed legislative intent to make prescription drugs more affordable and accessible by increasing state regulation of pharmacy benefit managers, PBMs, and to stabilize and safeguard against the loss of more independent and community pharmacies. That was the intent stated in Act 131. Section 1A had directed the Department of Financial Regulation to monitor the cost impacts of PBM regulation and recommend changes as needed to promote healthcare affordability. Section 2 had made some changes around the existing PBM regulation statutes. We have kind of a couple of different places in statute where PBM regulation currently lives. So you'll see when we look at H 233, part of what it's doing is kind of centralizing all of the PBM provisions in one chapter. So in existing section 18 BSA 9471, the definitions in Act 131 specifically removed Vermont Medicaid from the scope of the PBM subchapter and added a new definition of the term pharmacy benefit manager affiliate that comes up later on. The amendments in 18 BSA 9472, this is a section of law that's about PBMs and required practices regarding health insurers, and we added specifically and covered persons. The first thing it did was specify that PBMs owe a fiduciary duty to their health insurer clients. So they owe their health insurer clients a duty to be acting in the health insurer's best interests. The language prohibits PBM contracts with health insurers from allowing PBM to unilaterally move a drug to a higher tier in the formulary or remove a drug from a formulary more than twice per year. It also limited the amount that a PBM could require a covered person to pay for a drug to the lesser of the cost sharing amount under their plan, the maximum allowable cost for the drug, which is the amount the PBM will reimburse the pharmacy for the drug, and the amount the person would pay if they were paying the cash price for the medication. It also specified that the amount the covered person paid had to be counted toward their deductible and out-of-pocket maximum under their health insurance plan. And we're going to look at some of that language and expanding that in H 233. Section 2 also amended 18 BSA 9473, which deals with PBM required practices with respect to pharmacies. So 9472 was the practices relating to health insurers that are contracting with the PBMs and covered individuals. 9473 is looking at the relationship between PBMs and pharmacies. So it expanded the prohibitions on so-called gag clauses in PBM contracts with pharmacies and pharmacists. These are provisions that limit what a pharmacist or a pharmacy employee can say to a customer who comes to the pharmacy counter. It also prohibits PBM contracts from restricting pharmacies and pharmacists from disclosing certain information to the Department of Financial Regulation, law enforcement, or state or federal governmental officials. It prohibits PBMs from penalizing a pharmacist or pharmacy from disclosing information about PBM practices or from sharing a PBM contract with DFR. It requires PBMs to allow pharmacies to have certain appeal rights when claims are denied or not paid in full. Prohibits PBMs from reimbursing 340B covered entities. These are entities participating in the federal 340B drug purchasing program. So it prohibits PBMs from reimbursing those entities less for pharmacy dispensed drugs than they reimburse non-340B entities, or discriminating against 340B covered entities in a manner that would prevent or interfere with the patient's choice to get their medication from a 340B entity. It prohibits PBMs from reimbursing pharmacies or pharmacists in Vermont less than they would reimburse PBM affiliates. So when they have their own affiliated pharmacies, can't pay the Vermont-based pharmacies less than the PBMs would reimburse their PBM affiliates for providing the same services. Prohibits PBMs from imposing limitations or requirements on a licensed pharmacy that exceed those from the Vermont Board of Pharmacy that regulates pharmacies and pharmacists, or other state or federal law. And it requires PBMs to provide notice to participating pharmacies before changing their formularies. Then we have section 3, and I keep getting these controls in my way. So this is amending an existing provision, 18 VSA section 3802, which deals with pharmacy rights during an audit. And it talks about specific pharmacy rights when an audit is being conducted remotely. It shortened the period of time for delivery of both the preliminary and final audit reports to pharmacies. And it requires pharmacies to be provided with all payment data related to their audited claims. Section 4 is had amended 8 VSA section 4089J. So now we're in our health insurance statutes, and it's an existing provision on retail pharmacies and the filling of prescriptions. Excuse me. The first thing it did was add a definition, that definition of pharmacy benefit manager affiliate. It defined prescription drugs to specifically include the so-called pharmacy drugs. Just gonna get a sip of something. The mask is.
I have a whole projected.
Thank you. Projecting. It requires PBMs to allow participating network pharmacies to perform all pharmacy services within the statutory scope of practice for pharmacy that are in Title 26. It prohibits PBMs from requiring covered persons to use mail order pharmacy or it prohibits PBMs from requiring covered persons to use a PBM affiliate. And it prohibits them from increasing out-of-pocket costs, so making it cost more for a covered person because they didn't use a mail order pharmacy or PBM affiliate. It prohibits PBMs from having network requirements that are more restrictive than or inconsistent with state or federal law, Board of Pharmacy rules, or guidance from the Board of Pharmacy or drug manufacturers that would limit or prohibit a pharmacy or pharmacist from dispensing or prescribing drugs to the extent that's permitted. It prohibits health insurers and PBMs from requiring that a pharmacy they designate dispense a medication directly to a patient for the patient to bring to the provider's office to be administered there, or to a provider's office to be administered to the patient. So this is, some of you may remember the brown bagging, white bagging conversation from a few years ago. That's what these provisions are about. Then we get to section 5, which is the DFR PBM report requirement, and it had required DFR in consultation with interested stakeholders to consider whether PBMs should be required to be licensed, including the cost impacts in other states that have enacted licensure requirements, whether PBMs should be prohibited from using spread pricing, along with the Board of Pharmacy, looking at issues regarding pharmacist scope of practice, whether there should be minimum dispensing fees, how pharmacies should be reimbursed for a claim if a PBM denies an appeal, whether there is a problem in Vermont of pharmacies soliciting health plan beneficiaries directly to market their pharmacy services, and if so, how best to address that, and any other PBM-related issues. And DFR's findings and recommendations were due last January, and there's a link to the report. It's also probably on the website. It's on the website. We can put it on the webpage if it's not. And I think then we get into some applicability provisions, et cetera. So Section 6 specified that the PBM regulation provisions applied to contracts and health plans on and after January 1st of last year. And it gave PBMs doing business in Vermont on that date 6 months to come into compliance. Section 7 was an extension of an existing prohibition on PBMs imposing certain requirements on pharmacies related to 340B drugs. In a different bill last year, in your DEVA bill, Representative Goldman may remember, you got rid of that provision entirely. So you just got rid of the sunset. So the provision continues on. And Section 8 was the effective dates. Again, the PBM regulation sections took effect on January 1st of 2023. Everything else took effect in May of 2022. I think that is the end. Yes.
Questions?
More of a comment. I'm one of the people that worked on this bill, and it was a really important bill. And our independent pharmacy closed the summit in Dolls Falls. So it was a really good effort, but too little, too late.
Any other questions? Comments? Okay, thank you, Jen.
No.
Next, we're going to have Sebastian come up.
It's right there. Yep. I had to move.
Somebody else got it. I didn't see it.
Sebastian Lego for the Department of Financial Regulation. Before we get into the report, we're going to do a refresher course.
Excellent.
Picture. Okay. So, just wanted to remind everyone of where PBMs are and how to conceptualize the whole product and money track. So I've attempted to draw it out here, and this is a gross oversimplification, but I hope it will help you.
I love your asterisk.
Yeah. I hope this will aid in understanding.
It is so good.
So,
Is this just a commercial market?
yes.
Okay, not Medicaid.
Not Medicaid.
Okay.
Again, gross oversimplification. I don't know how many of you have seen The Wire, but there's a great scene in the first season where Lester Freeman, who's one of the cops, says that if you follow the drugs, you get drug users and drug dealers. But if you follow money, you don't know where it's going to take you. And that's sort of the case with the legitimate drug market too.
Or illegitimate.
So let's start by following the drugs. So drugs, if you'll recall, start out at manufacturers who sell to wholesalers. The price at which manufacturers sell to wholesalers is generally called the list price. Okay, so now the drugs are at the wholesalers. Because this is an oversimplification, we're glossing over a couple of different layers of middlemen because bigger pharmacies buy drugs from bigger wholesalers. And there are bigger wholesalers and smaller wholesalers and distribution centers. And we're going to gloss over all of that stuff and lump all of those entities together. For the purposes of this illustration, what's important is that pharmacies buy drugs from wholesalers. And the price at which they buy those drugs from the wholesalers is the wholesale acquisition cost, or WAC. Wholesale acquisition cost. Okay, so now the pharmacy has a drug, and if you don't have insurance, what you will pay is the shelf price for that drug that is set by the pharmacist that will typically allow for some profit margin, just as if you were buying a hammer from Ace Hardware. But if you have insurance, the situation changes, and now we need to follow the money. Okay, so let's say that you have insurance. Your insurance doesn't directly reimburse the pharmacy. Your insurer likely has a contract with a pharmacy benefit manager to manage the plan's pharmacy benefit. We'll say contract. So what do pharmacy benefit managers do? Again, in a gross oversimplification, you can think of what they do as twofold. First, they negotiate rebates with manufacturers in exchange for preferential treatment on the PBM's formulary. What does that mean? So the manufacturer will pay the PBM money, and in exchange, the PBM will say that manufacturer's brand name drug has a preferential spot on the formulary. And if you'll recall from our discussion last time about how formularies work, formularies are typically on different tiers. So in an extremely simple example, you might have an A tier with a $10 copayment, and a B tier with a $25 copayment, and a C tier with a $100 copayment. And what the rebates allow manufacturers to do is get their more expensive brand name medications on those lower cost sharing tiers, meaning that patients are more likely to use those medications, even if there's a generic equivalent available. So if you're ever at the pharmacy in a situation where you would have less out-of-pocket cost sharing for a brand name drug as opposed to a generic, this is why. Okay, so the other thing that manufacturers do is they reimburse pharmacies for those prescription drugs. And the rate at which the PBM reimburses the pharmacy for generic medications, again, just for generics, and this is a term that comes up a lot, so I just want to kind of try and give you a sense of what it is the MAC price, or the maximum allowable cost. Okay, so one of the issues that Act 131 was trying to address is that this price, the wholesale acquisition costs, and this price, the maximum allowable costs, don't really bear any relation to each other. And pharmacies can end up in situations where they're being reimbursed an amount in their maximum allowable cost from the PBM that is lower than their wholesale acquisition cost. effectively losing money on every script. Okay, so that was the extremely simple version of this where all of the players are separate. In the real world, this is a lot more complicated. And what has happened is that, especially on the money track, the players are becoming more integrated. So PBMs own pharmacies and are thus directly not only negotiating rebates from manufacturers, but buying drugs directly from manufacturers. And this has happened, it started in the specialty space, but is now moved into more traditional brands and generics. So if you hear testimony about vertical integration in this space, what's being discussed is this, that these two entities on the money track are basically collapsing into each other. Okay, so
So can I ask a question about that?
I have a
Yes.
question too.
Is that a bad thing? Or like, how does that affect the pharmacy compared to what you just described, where the pharmacy might be losing money on every prescription?
So how this affects the pharmacy is that the independent pharmacies that are not vertically integrated with a PBM can be at a competitive disadvantage. Because remember, PBMs reimburse pharmacies. So where this leaves independent pharmacies is almost in the position of being reimbursed by their competitors.
Okay, that makes sense. Maureen?
So it goes a little bit, there's even more to the vertical integration in that some of the bigger vertical integrations have pharmacies, they have PBMs and insurers. So like I just pulled up real quickly an example of Blue Cross, Prime Therapeutics, Alliance. All three are captured. So they have, I think there's like three major vertically integrated PBMs that have like somewhere between 90 and something % of the market.
Yes. That's absolutely correct. In addition to this kind of vertical integration, there is a lot of market consolidation too. So there's an entire section about this in our Act 131 report. But the short of it is that there are 3 PBMs, and we'll call them out by name, but they're so big that you will have heard of all of these. CVS Caremark, Express Scripts, and Optum collectively account for about 75% of the PBM market. Everyone else are kind of bit players.
It's the independent pharmacy. Is there any reason that they can't just go directly to the wholesaler?
What a great question.
Say that again.
Yes.
Can you say it again?
Is there any reason why an independent pharmacy cannot go directly to the wholesaler?
So now we're back. This is a question that relates to the money, to the product track. And the most simple way that I can put it is that so imagine that the difference between like Ace Hardware and a hardware store that's unaffiliated with like Ace or Aubuchon or any of the big hardware store chains. the Ace hardware store can access Ace's distribution network and buy their tools at wholesale for less than an independent hardware store that only has access to smaller wholesalers. Does that make sense? That independent pharmacies don't have the economies of scale that are necessary to do business with the biggest wholesalers. So they have to deal with intermediaries that are 1 or 2 steps down the chain.
So that means that because they're smaller, their price, even their wholesale price, is going to be bigger. Is that?
Yes,
That's the problem.
yes.
I had a
I'm
question.
sorry, go ahead, Bobby.
So you said manufacturers provide rebates to the PBM so that they can get their drugs on a lower tier,
Yeah.
right? Would it be at a point where the manufacturers sometimes take a loss in order to get brand loyalty or some like market saturation point out of this, or?
It's unclear whether they take a loss because the pricing structure is so opaque and there are so many inputs that go into developing a successful prescription drug. I mean, some of these drugs are on the market for years before they're able to turn a profit. But I think it is safe to say that manufacturers will apply very generous rebates to drive sales of specific prescription drugs.
Melanie, let me look at the little picture. So does that mean like if you're vertically aligned, you can get lots of rebates from the manufacturer and like hike up the MAC and like have like 2 revenue streams, basically getting it for cheaper and then asking for more?
So that can be a business advantage of a vertical integration. It's well outside of the scope of what you legislated in Act 131, but those kinds of concerns are animating an FTC investigation of the PBM industry that's currently underway.
Sorry.
We're going to be talking about that issue as we go forward. And would it be fair to say that, especially since Rutledge, a Supreme Court case that kind of opened the door a little bit, there was a lot of opacity throughout the whole system where until now, where states and, as you mentioned, the federal government are trying to open up those. Take a look at trade secrets, proprietary information that PBMs were clamping down on.
Yeah, so I'd like to address that really quickly because that is something else that will, I don't need the whiteboard for Rutledge. So 2 years ago, the Supreme Court of the United States decided a case called Rutledge versus PCMA. And the issue that the court considered in that case was whether legislation to regulate the PBM industry in Arkansas was preempted by ERISA. ERISA is a law that comes up a lot here because what it says is that states cannot regulate self-insured employer-sponsored health plans. And the PCMA, which is the lobbying group that represents the drug manufacturer, or sorry, that represents the pharmaceutical industry, took Arkansas to court claiming that under ERISA, these regulations were preempted, at least with respect to the self-funded plans. And the Supreme Court said, no, as long as the states are not dictating what plan benefit should be and only incidentally adding cost to plans, that is completely permissible under ERISA.
Okay. All right.
As we look at this and the vertical integration you showed, what does all of this, the vertical integration and the possible restrictions on PBMs do to the price of drugs to the customer?
I think there's a lot of debate on that goes both ways. I think that the proponents of the industry would say that vertical integration and economies of scale allow patients to have easier and cheaper access to prescription drugs. Conversely, there are studies going the other way and saying that market consolidation makes prescription drugs more expensive and exacerbates access to care issues by driving smaller and independent pharmacies out of business.
Okay, thank you.
More question? Yeah. Last year we had testimony from a gentleman who represents the independent pharmacies. I believe his name is Jeffrey Hochberg. He was telling us that about somewhere between 50-60% of the cost of drugs was the manufacturer at marketing to the PBMs to get their. Is that number close to what you understand? I mean, it seemed crazy, like half the cost.
So I know Jeff, and I respect his deep knowledge of the industry. I don't know if I would agree with some of his testimony, and then that the PBMs are the entities that are in control of the whole healthcare system. But in our research for the Act 131 report, we did find some evidence of the effect of rebates on overall healthcare costs that I think merit some explanation. So I'm going to flip to the right page in the report and then share my screen so I can show you. Now I need to zoom in. Okay. So in this example, there's a drug with a $100 list price and a 20% rebate that PBM has negotiated with the manufacturer. Because the cost of that rebate essentially flows through the entire payment system as shown in this diagram, the overall cost for this script is $107. So this doesn't mean that the patient necessarily pays more out of pocket. It's that when all of the costs that flow from the rebate add up, they make the drug that has $100 list price and a $20 rebate cost the system $107. So when we talk about like the cost of care, like this is the kind of thing that we talk about. And then in the second example, and again, if you want to reference this chart, it's in our report. The same drug, if it was sold with a list price of $80 with no rebate, the overall cost to the system is less.
And the PBM keeps less, everybody gets a little less, but
So I'm sorry, but in the first one, isn't the list price $100?
Yeah.
Yes,
With a 20%
with a
rebate.
20% rebate.
So you're using 80 as the, okay, I was thinking,
20% or $20? Oh, well, $20 is.
Yeah.
yeah.
can you scroll it so you can see both of those tables with the numbers
Yeah.
at the same time? Yeah, because
One second.
Yeah.
it just seems like the PBM benefits the most from having the rebate in that.
Yeah, so this is an argument that has been made about rebates, that PBMs tend to benefit the most from them.
Chopper and then Art.
And so the patient, me, I'm on the end of this thing. What's the value of all of that rebate and all that stuff with the PBM in terms of
Yeah, so
purchasing
yeah,
that particular drug?
so the upshot for you as a patient, and especially in a state like Vermont, because in Vermont we have an extremely low out-of-pocket max for prescription drugs. The number is indexed to the federal poverty limit, but off memory, I don't think it's more than $4,000 for an individual in 2024.
That we can pay out of pocket. for all our-
Yeah, your maximum out of pocket for prescription drugs is quite low. So the upshot for you as a patient is that you can go to the pharmacy and be able to access a brand name drug with either a lower out of pocket than you otherwise would have had if that drug had not been rebated, or with no out of pocket because you've already hit your out of pocket max. The downside for you and for everyone is that your premiums are a little bit higher than they otherwise would have been.
Would have been if
There were no rebates.
there were no rebates. Okay. Art?
Yeah, and this is just a structural question. When I hear the word rebate, I think of something totally different than what this seems to be. Is that ever come up? Because it almost seems to be pay for play.
Yes.
That's what it makes me think of.
Yes. So if you or I get a rebate, it's the kind of thing where like you bought something. Let's say it's a lawnmower, and you get a $200 manufacturer rebate. So you buy your lawnmower, you fill out the form, you send it in, and then 2 months later you get a check for $200.
Right.
Rebates in the prescription drug world do not work like that, because it is the pharmacy benefit manager that negotiates for those rebates and not the manufacturer giving them directly to you. One of the reforms that we discuss in the report is the idea of requiring full rebate pass-through, so that if the manufacturer negotiates a $20 rebate with the PBM, you as the patient sees that full $20. But again, one of the criticisms of rebates in general is that, like, yeah, even though like you get that $20 benefit and it's great, everyone are still paying slightly higher premiums.
Well, it sounds, if I understand this right, all the rebates are doing is allowing the manufacturer to get their drug on the formulary.
Yep.
So it's really like you're paying to
They're paying to get, yeah, they're paying to get sales.
Payola, like in radio.
Yeah, it's just different.
I think that's the right thing to say.
Yeah, it's
Right?
just a
Pay to get
different
on the
than
formulary.
rebate. Rebate is a whole different thing to me, but anyway, we don't have
Yeah,
to go down.
you could call it something else if it helped you to
Really.
understand it.
Payoff?
Okay.
Okay, we're gonna be.
I think there'd be some objections to that, but
Let's be nice.
So is it safe to say that if I'm a manufacturer and I'm gonna sell this drug for, I have an established price that I'm gonna sell for $100, that, and then I'm negotiating with the PBM, and the negotiation comes out to a $20 rebate, then I can turn around and say, okay, I'm gonna sell the drug for $125. You're gonna get a $20 rebate, and all the people, me, are gonna pay more.
so
Is that, can that happen?
it can happen. I think last week there was some discussion about copay accumulators. So one of the reasons that PBMs and health plans design formularies the way they do is to minimize the cost to the plan. If they get those rebates from the manufacturer, that's great. Those drugs will have preferred placement on the formulary. If they don't, they will put the least expensive drug in whatever pharmacological class they can find on the formulary. So what manufacturers can do if they don't get that premium formulary placement is to say that, like, well, in order to give people access to our wonderful brand name drug, we will give out coupons to cover the co-payments. And remember, because our out-of-pocket max is so low, in some cases, it doesn't take many months of coupons before the plans are completely paying for the cost of that drug. So the plans have said with copay accumulators, like, hey, like, these coupons are undermining our formulary and getting our members stabilized on these more expensive brand name drugs that, like, we now have to pay for once they hit their out-of-pocket max. So that's a way in which the manufacturers can try and influence what a patient might pay out of pocket. And again, for you as a patient, this is great. Like you get access to the brand name drug. The manufacturer is picking up your copays, and then when you've hit your out-of-pocket max, you don't have to worry about it anyway. But for the system as a whole, the plan ends up paying more.
We all pay more in premiums.
Yeah,
Yeah, every month
yeah.
we're paying more in premiums.
Okay. So did you have more? Were you going to go over the recommendations in the report?
Yes.
Or the bill? Okay, great.
So we made one overall recommendation in our report, and I'll scroll right there.
Everybody should read this
Yes.
incredible piece of work.
Yes. We
By the way,
should.
it's really remarkable.
Very well done.
Okay, so our top line recommendation is to require licensure and increase regulatory oversight of PBMs. So under Act 31, there are standards of conduct, both with respect to PBMs contracts with insurers and with pharmacies that PBMs have to abide by, but we can't stop them from doing business in the state because they don't need a certificate of authority from the department to do business here. So we can find them, but we feel like having these entities be licensed and subject to our jurisdiction and subject to the ultimate sanction of being prohibited from doing business in the state would give some teeth to our enforcement.
Oh, hold on. Okay.
Is the oversight done by the regulatory board?
By you, DFR?
Yeah. So based on what other states have done, and there's a whole section about this in the report where we've cited to fiscal notes in other states. We estimate that if something like this were enacted, we would need 3 FTEs to bring this licensure and enforcement program up to snuff. And I believe you have a cost estimate for that from JFO.
Yeah, we'll be getting to that. Leslie?
I'm not sure this is the time, but I'm just wondering, are these recommendations in 233? Can we cross
Yes.
that?
Yes.
So
There's,
if we just make that connection, that would be
we
great.
will.
Okay, so
Yes.
these are in the bill.
Not
Not
necessarily.
necessarily, but we will
Yeah.
make the cross connection.
Yeah.
And then we can decide what.
Was this one in the bill?
Can we wait until we review the bill?
How many other states have this type of, we have oversight of?
Yeah, about 2/3 of the state. There's an appendix in the report where
Sure.
we show all of the states and what kind of legislation they have in place.
Yeah, and rural states?
Yes,
Okay.
I think more have looked into
yes,
similar legislation since the report.
yes. And I would say that the Rutledge decision has really opened the floodgates to states that were hesitant about this before. So we also included a number of other policy options. These are not recommendations, but just policies that the legislature could consider. So first would be expanding spread pricing disclosures to health plans. We talked a little bit about spread pricing last time, but in a nutshell, what it is that when the insurer is paying the PBM for their services, there are 2 basic ways they can do that. One is called pass-through pricing, where the PBM says, well, this is what we paid the pharmacies, and we'll tack on a percentage as an administrative fee. from the insurer's perspective, the problem with pass-through pricing is that because the cost of drugs is variable, the cost of having the PBM manager drug benefit would then be variable. And as an insurance company, you want to eliminate variable costs as much as you can. So the alternative that a lot of insurance companies use is called spread pricing. But what it is the PBM saying, when you reimburse us, you will reimburse us a price certain for every prescription drug. And sometimes that price is more than what the reimbursement paid to the pharmacy was, and sometimes it's less. So the PBM industry views it as a risk mitigation pricing strategy that offers a value to insurers, since it gives the insurers price certainty. The problem with this that we noted in our report is that because prices throughout the money track are so obscured, it's very difficult for insurers to know whether they're getting a good deal unless they're continually doing audits. Some insurers can do this, but as a means of just ensuring that the insurers that want to take advantage of spread pricing are getting a good deal, we'd like to just suggest expanding disclosures as an option. The second policy option that we wanted to suggest was expanding the MAC appeal process. So remember how I talked about the MAC price? This is the minimum allowable cost. This is what the PBM reimburses to the pharmacy. Doesn't have any relationship to the wholesale acquisition cost, which is what the pharmacy paid for the drug. Act 131 introduced an appeal process for the pharmacy to be able to say, like, wait a minute, like I could not acquire the drug for the price that you are reimbursing me. We suggested that there are some improvements that could be made to this process, like a simple one would be allowing pharmacists to batch similar claims. So if they dispensed like 100 doses of drug X in a month, they wouldn't need to appeal all of those individually. They could just batch them together and get that resolved more expeditiously.
I think we have a question. Go ahead, Mike.
Yeah, just out of my head. I think a question and a comment. I think one important piece about then back up to under expanding spread pricing disclosures to health plans. Insurers insurers don't know what the pharmacy is getting reimbursed by the PBM for each individual medication. So insurers don't know when the pharmacy is getting reimbursed less than what it costs for them to dispense the medication. They get aggregate information, but they don't get a drug by drug amount.
That's correct.
Okay. And I'm thinking while we're talking about all the pricing and the rebates, PBMs need a way to get revenue. Is that something you can, off the top of your head, like list the ways that PBMs keep their business afloat?
We talk about this in the report, but in general, they either make money off of the spread, they can make money from administrative fees in a pass-through pricing model, or they can make money from direct and indirect reimbursement fees, which, because of a recent rule change in Medicare Part D, will probably be less of a revenue stream for PBMs going forward.
Thank you.
So one of the things we looked into in the report was PBM solicitations, and we found that some of the marketing practices that PBMs use could be really to the detriment of consumers, and don't allow independent pharmacies to compete on a level playing field. So there were some actions in other states that we suggested that the legislature look into, such as codifying that the patient's pharmacy belongs solely to the patient, and prohibiting third parties from altering scripts or the pharmacy chosen by the patient without the consent of the or their provider, applying advertising standards that are applicable to health insurers, to PBMs, and giving the department authority to approve solicitations sent by PBMs to members of health insurance plans. Then the
1 second.
What you just said then, how does that get around the regular, I don't know whether it's a law or regulation or whatever it is, but when you go to the pharmacy, if you're looking for a brand name, it's gonna switch to the generic. How does what you just said?
right, so like if you consent, then the pharmacist could make the switch. But the PBM couldn't, if your provider had written you a script for brand name X, and then your PBM saw that and said, well, brand name X isn't on the formulary, we're going to switch this to generic X. They couldn't do that without getting in touch with you or your provider.
Nobody, okay, I've had prescriptions. I go into the pharmacy and I get the generic. I don't get it. Provasticin or something like that it's called. I go in there, I get the generic. I don't get the brand name
Yeah,
automatically. No one says to me, hey, do you want this topper?
That's the state's generic substitution.
Yeah.
Right.
Yeah. Well, is that a law?
Statute, yep.
Yeah, I thought it was. So how does this fit into that?
so where this would fit in is there have been cases that we've documented here or and in other states too, where a patient's script might be switched from their local pharmacy to the PBM's mail order pharmacy without their consent. That's really what this policy suggestion is getting at.
All right, and then Mari, and then I want to make sure Sebastian has time to finish because.
Okay, yeah, I just want to chime in
Yeah.
quickly on that. What you just said happened to me. And it just happened. I took a drug, went to the local pharmacy, and pretty soon I got a Express Scripts thing, and I just started using the Express. I didn't think anything of it. And it's easy and it's cheap, so that's what I did. But yeah, it happened out of the blue. Strange.
All right,
It happens a lot for example, with inhalers. I've personally experienced my provider prescribing one inhaler and then over a relatively short period of time have had to switch what medication I'm using because the PBM changes their formulary or there's some other change. And I don't know about that until I go to refill my prescription and then there's this like delay of treatment because then I've got to go back to the provider and say, hey, they're not going to cover this. They want you to prescribe, the PBM wants you to prescribe this medication instead. And then I've got to wait for all of that to go through. So it's especially problematic with medications like inhalers, the more expensive medications.
But what other states have done and the issue that it's trying to address is described in detail in the report. So I would encourage all of you to take a look at that when you have a chance. And then the last policy suggestion that we have is setting loss ratios for PBMs, similar to how insurers have loss ratios to basically to ensure that a certain percentage of the revenue that PBMs accrue through spread pricing or administrative fees goes to purchasing drugs, reimbursing pharmacies, and that PBMs are capped on the profits they can make from especially spread pricing models.
so I have a question. If we would to, implement all of this, pass legislation that we do this, what, if any, effect would it have on provider burden, including pharmacists, obviously, access to healthcare and cost to prescriptions and or premiums?
Yeah, so in terms of provider burden, there are a lot of headwinds, especially for independent pharmacies, that this legislation is not going to address. I think Representative Goldman spoke to her experience with her local pharmacy in Bellows Falls, and none of these policy recommendations will change the dynamic that independent pharmacies are, effectively competing with vertically integrated corporate behemoths.
Yeah.
So I think this will not really affect the burden of running that kind of business. I think in terms of costs, I think there is a balance, because like I was talking about before with the effect of rebating, for you individually as a patient, rebating is great. For everyone collectively, rebating is bad. And legislation in this space will involve thinking about what kind of trade-offs you want to make. Do we want to make prescription drugs more accessible to individuals at the expense of premiums being higher? Do we want to make it easier for independent pharmacies to stay in business at the expense of increased prescription drug costs? Like those are the kind of trade-offs that you'll be grappling with.
That's very helpful, yeah.
The crux of the whole thing
Yeah,
right there.
really.
Good. All right, anything else?
Any questions?
So I'm wondering how this gets enforced. I'm looking at your other, what your recommendations are. Is that what the extra staff and DFR do? They enforce this? Or could you make?
Yeah, so because we'll have a bunch of new entities being licensed for the first time, we anticipate needing additional staff in company licensing, and then we'll also need additional staff in market conduct, preferably with experience in pharmacy to help parse through all of the potential issues that need to be enforced.
All right.
Do you anticipate that there will be an increase in, if we pass the licensure requirement, that there will be a greater number than are currently registered? Does that make sense? So we have a list of who's registered now.
Yeah. So again, because of the vertical integration that we've talked about, there are entities that are registered for VCures, which is our all-payer claims database, like as insurers, but they also provide pharmacy benefit manager services. So to the extent that those entities are coming into the department's regulation as of PBMs, there will be more than just the 30 or so entities that are registered in VCures solely as PBMs.
And some of the PBMs could be PBAs or PBMs that just administer
Yes.
for insurers. Can you
Yes.
explain that a little bit?
Yeah, so if we go back to my extremely simplified diagram, there are middlemen throughout the money chain, and I think ideally we would like to be able to license and regulate all of the classes of entities that perform pharmacy benefit management services, no matter who their clients are or what market niche they serve.
Yeah, it's helpful. Thank you.
Leslie, and then and then Melanie, and then we'll go to Jen.
So I was just looking at Jen's summary of 131 that we started with, and one of the bullets was stabilize and safeguard against the loss of more independent and community pharmacies. But I just heard you say, I'm just trying to reconcile that intent with what you just said, which that it won't protect community pharmacies, and I want to see what I'm missing.
Yeah, so we can make it easier for community pharmacies. We can make it easier for them to appeal. I think the bill that you're considering makes some changes to wholesaling, which I'm not going to address here, but are intended to make it easier for community pharmacies to document the wholesale cost. But at the end of the day, community pharmacies have to compete with CVS and Walgreens. And none of what we're doing here changes that.
Thank you.
How much does it cost to register as a PBM right now? Is there a fee to that?
I don't know off the top of my head, but I believe it's either in statute in 18 VSA 9410, or it's in the Green Mountain Care Board's data submission rule. But it is a minimal, if there is a fee, it's a minimal fee just to cover the cost of administering the cures.
So when you do the licensure of this, for these recommendations, would there be a different level of fee to be licensed to help for those 3 FTs? I just was curious the connection of those.
That's in the bill, and so we'll discuss it. Okay, yeah. Thank you. Yep. Thank you, Sebastian, very much.
Thank
As
you.
always, very informative.
As always.
Yeah.
There'll be a test at noon.
Right, exactly. I might skip that class.
Yeah, I don't think I'll.
Walk through the bill? Sure.
How many times have we heard this?
I know.
And it's still.
Every time I learn
I
something.
know, a
yeah.
little bit.
Yeah.
Yeah.
So it's just a business, it's business. Crash.
First time fully go over me.
No, you look good. There's a little right there.
It's a wholesale model.
That's what I got.
So I just want to remind everyone, we are still live. And we are not muted.
You had 131. So are we just adding to that or
It's a whole new bill.
so what do you do with the other one?
No, it's in
Stays, so
statute,
we're
yes.
just adding.
We're building on to what the statute is potentially, yes.
A lot of what's in the new bill is what we couldn't get to the last biennium. With some extras.
So we'll have Jen walk through the bill and then we'll take a break.
I know. Brilliant.
All right, again, Jennifer Carvey, Legislative Counsel. So we will now walk through H 233. I also put together something that I had done when we had done what became Act 131, which is that I was just finishing over there, which is to do a sort of side-by-side of the provisions in H 233 with existing law, because a lot of what's happening in H 233 is that we're striking out existing law and creating a comprehensive chapter. And so it's hard to tell what's actually new versus what is underlined because it's being codified in a new place. So we can walk through the bill, but we can also look at that document if that is helpful. So I, yes, stayed in the Zoom room. And one other just clarification I wanted to make based on something I heard Sebastian say, which is just the out-of-pocket maximum for prescription drugs under Vermont law is not tied to the federal poverty level. It's tied to federally set minimum thresholds for a plan to qualify as a high deductible plan. So the deductible for a plan to qualify as a high deductible plan is a number that the Fed set under the IRS regulations. It is currently $1,600 a year for an individual, and I believe usually it's $3,200 for a family, or doubled for a family. So I just wanted to, or yes, $3,200 for family coverage. So I just wanted to clarify that that's the basis for that calculation. All right. 233. All right, so this is H 233. This is an act relating to pharmacy benefit management and Medicaid wholesale drug distribution. Section 1 is where we would be adding a new chapter on pharmacy benefit managers. So as I said, this takes a lot of provisions of existing law and puts them all into one chapter instead of they're kind of spread throughout an existing chapter. So this would be 18 VSA Chapter 77, would be a new chapter on pharmacy benefit managers. It starts out with the purpose statement. The purpose of the chapter is to establish standards and criteria for the licensure and regulation of pharmacy benefit managers, providing claims processing services or other prescription drug or device services for health plans by promoting, preserving, and protecting the public health, safety, and welfare through effective regulation and licensure of, just going to call them PBMs.
Yeah, I have a question on this, Shannon. It has to do with Melody's last question. Didn't you ask whether pharmacy benefits managers are registered and how much it would cost? So we're going to register and now license? What's the?
Yeah, so can we hold that till after we walk through the language?
Sure.
Okay.
Yeah.
That'd be great.
All right, so it's creating a system of licensure and regulation for purposes including promoting, preserving, and protecting public health, safety, and welfare, promoting the solvency of the commercial health insurance industry, and it's got some citations to the fact that that is a state function, as well as providing for consumer savings and fairness in prescription drug benefits, providing for the powers and duties of the Commissioner of Financial Regulation and prescribing penalties and fines for violations of the chapters. And kind of setting out some overarching purpose parameters for the chapter. Then there are a bunch of definitions, most of which I don't think we need to look at now, but I do just want to mention a couple of them. So one is that term maximum allowable cost that Sebastian had talked about, because it'll show up later, and it's the same definition we have in existing law, just moved. But pharmacy benefit management, I think, is important because Sebastian was just saying toward the end of his testimony, if the purpose is to regulate this kind of activity, regardless of how the type of entity might identify itself, then I think it's going to matter how you describe pharmacy benefit management. So in the bill, it is, and this is similar to what's in existing law, an arrangement for the procurement of prescription drugs at a negotiated rate for dispensation within this state to beneficiaries, the administration or management of prescription drug benefits provided by a health benefit plan for the benefit of beneficiaries, or any of the following services provided with regard to the administration of pharmacy benefits: mail service pharmacy, claims processing, retail network management, and payment of claims to pharmacies for prescription drugs dispensed to beneficiaries, clinical formulary development and management services, rebate contracting and administration, certain patient compliance, therapeutic intervention and generic substitution programs, and disease or chronic care management programs. So it's a fairly broad definition. We can look at whether it needs changes, but I think it sweeps in a lot of the types of actors Sebastian was talking about. And then important also to know what the term pharmacy benefit manager does not include. And the biggest one that was specified in Act 131 that would be carried over here is an entity that provides pharmacy benefit management services for Vermont Medicaid. We're letting Vermont Medicaid operate the way it has been under its own different incentive and rebate programs, and not regulating their PBM in this chapter. And then there's that pharmacy benefit manager affiliate definition that was also added in Act 131. It would give DFR authority to adopt rules to carry out the provisions of this chapter. DFR does have existing rulemaking authority in a number of different places, but the one that applies in some of the PBM contexts seems fairly limited to administering the provisions of one section, ATVSA 9421, and not other sections, although there is broader DFR enforcement language in existing law as well. So this would allow DFR to adopt rules specifically to carry out the provisions of this chapter, and would direct that the rules include, as appropriate, requirements that health insurers maintain the confidentiality of proprietary information, and that PBMs file their advertising and solicitation materials with the Commissioner of DFR prior to sending for approval, prior to sending them to patients or consumers. So this is something that would be new. Section 3604 would require an annual report from DFR to this committee and your Senate counterparts regarding PBM's compliance with the provisions of this chapter. So those were all the kind of general provisions in what would be subchapter 1. Then we get to subchapter 2, which is the PBM licensure and regulation. So the first section here is licensure. This would create a new licensure requirement. It says a person shall not establish or operate as a pharmacy benefit manager for health plans in this state without first obtaining a license from the commissioner of DFR. And it would require a person applying for a license to submit an application for licensure as prescribed by DFR and include a non-refundable application fee of $100 and a licensure fee of $500. It would allow DFR to refuse to issue or renew a PBM's license if the commissioner determines that the applicant or anyone responsible for the conduct of its affairs is not competent, trustworthy, financially responsible, or of good personal and business reputation, or has been found to have violated the insurance laws of this state or any other jurisdiction, or has had their insurance or other certificate of authority or license denied or revoked for cause by any jurisdiction. Unless it is otherwise surrendered, suspended, or revoked by the commissioner, a license would remain valid as long as the PBM continues to do business in this state, comply with this chapter and any applicable rules. And submits a renewal application and pays an annual license renewal fee of $500. And it talks about when and how that would be due. And again, directs DFR to adopt rules establishing the licensing application, financial and reporting requirements for PBMs. Then we get into a lot of prohibited practices. Many of these are already prohibited under existing law, but again, sort of centralized here. A participation contract between a PBM and a pharmacist shall not prohibit, restrict, or penalize a pharmacy or pharmacist in any way from disclosing to any covered person any healthcare information that the pharmacy or pharmacist deems appropriate, including the nature of treatment, risks, or alternatives to treatment, the availability of alternate therapies, consultations, or tests, the decision of utilization reviewers or similar persons to authorize or renew or deny services, the process used to authorize or deny services, or information on, and I think this should say financial incentives and structures used by the health insurer. Also, PBM shall not prohibit a pharmacy or pharmacist from discussing information about the total cost for pharmacist services for a drug, providing information to the covered person about their cost-sharing amount for the drug, disclosing to a covered person the cash price for a drug, or selling a more affordable alternative to a covered person if a more affordable alternative is available. Then it also says that the PBM contract with a participating pharmacist or pharmacy shall not prohibit, restrict, or limit disclosure of information to DFR, law enforcement, or state and federal governmental officials, as long as the recipient of the information represents that they have the authority to maintain that information as confidential, and before disclosure of confidential information, the pharmacist or pharmacy marks as confidential any document in which the information appears and requests confidential treatment for any oral communication of the information. Again, we'll look at the chart, but a lot of this is existing law. Also says that a PBM shall not terminate a contract with or penalize a pharmacist or pharmacy due to the pharmacist or pharmacy disclosing information about PBM practices, except information determined to be a trade secret under state law or by DFR, when disclosed in a manner other than in accordance with subsection C, that's the confidential language, or sharing any portion of the PBM contract with the commissioner pursuant to a complaint or query about the contract's compliance with this chapter. So that was a lot about the PBM and the pharmacist or pharmacy. Then it also says a PBM shall not require a covered person purchasing a covered drug to pay an amount greater than the lesser of the cost sharing amount under the terms of their health plan, the maximum allowable cost for the drug, so that's how much the PBM is going to pay the pharmacy, or the amount the covered person would pay for the drug after application of any known discounts if the covered person were paying the cash price. And then it says, as used in subdivision 1A, the cost sharing amount under the terms of the health benefit plan will be calculated at the point of sale based on a price that has been reduced by amount equal to at least 100% of all rebates received or to be received in connection with the dispensing or administration of the drug. And the PBM would be required to pass on any remaining rebate amount in excess of the covered person's cost sharing amount to the health plan to reduce premiums. And then subdivision 3 here is this, what's been referred to as the copay accumulator. So under existing laws, the PBM is supposed to attribute any amount paid by a covered person toward their out-of-pocket requirements. This would specify that the PBM must attribute any amount paid by or on behalf of a covered person, including any third-party payment, financial assistance, discount, coupon, or other reduction in out-of-pocket expenses made by or on behalf of a covered person for prescription drugs, toward any deductible and to the extent allowed under federal law, annual out-of-pocket maximums under the plan. This would be allowing amounts paid on behalf of the patient, not just the patient's payments, to be counted toward their out-of-pocket responsibility under the plan. And then this small sentence at the top of page 12 would prohibit PBMs from conducting or participating in spread pricing in this state. That was one of the things, one of the topics Sebastian talked about. Then we get to enforcement and a right of action. So it directs the commissioner of DFR to enforce compliance with the chapter, allows the commissioner to examine or audit the books and records of a PBM providing claims processing services or other prescription drug or device services for a health plan to determine compliance with the chapter. Information in the acquired in the course of an examination or audit would be considered proprietary, confidential, exempt from public inspection and copying under the Public Records Act, not subject to subpoena, and not subject to discovery or admissible in evidence in any private civil action. So a lot of confidentiality, for a lot of protection for that information. This would give the Office of the Healthcare Advocate the right to receive or review copies of all materials provided to or reviewed by the commissioner under this chapter in order to protect and promote patients' and consumers' interests in accordance with the office's duties, and would prohibit the Office of the Healthcare Advocate from further disclosing any confidential or proprietary information provided to the office. Would allow the commissioner to use any document or information provided pursuant to subsection 3612C or D of this chapter.
I have a question, Jen. How much of all the we've gone over so far is new or as opposed to?
That's what I will go over that. I have a separate chart that I made for you that tries to tell you
Wonderful.
what's what, yes. So I think this whole enforcement section is new. All right.
It's all still section 1, right?
This is all still section 1 because the whole chapter.
Great.
So yeah, so there's sections within it of statutory language. This allows the commissioner to impose a penalty on a PBM or the health insurer that it's contracted with, or both, for violating the chapter. And it would say the penalty would be not less than $25,000 nor more than $50,000 for each violation of this chapter. It also allows a pharmacy, pharmacist, or other person injured by a PBM's violation of the chapter to bring an action in superior court. So this does create a private right of action as well. 3614 is a new provision, although it's sort of generally, I think, implied throughout our statutes, which is nothing in this chapter is intended or should be construed to conflict with applicable federal law. So we're not trying to do anything we're not supposed to or allowed to do under federal law. 3615 allows the Department of Financial Regulation to charge its reasonable expenses in administering the provisions of this chapter to PBMs as provided in 8 BSA section 18. This is similar to language in existing law as well. These expenses would be, it talked about how they would be allocated in proportion to the lives of Vermonters covered by each PBM. And it says that DFR would not charge as expenses to the PBM contracting with DIVA if DIVA notifies PBM of the conditions contained in its contract with a PBM. And we can ask DIVA if that is necessary if Medicaid is carved out. Then section 3, we get to PBM relations with health insurers. So the first deals with insurer audit of PBM activities, and this is language from existing law as well. It allows in order to enable periodic verification of pricing arrangements in administrative services only contracts. It requires PBMs to allow access by the health insurer who's party to the contract to financial and contractual information necessary to complete an audit to verify full pass-through of negotiated drug prices and fees associated with drugs dispensed to beneficiaries of the plan in retail and mail order settings, or resulting from any of the PBM functions defined in the contract, full pass-through of all financial remuneration associated with all drugs dispensed to beneficiaries, and any other verifications related to the pricing arrangements and activities of the PBM required by the contract, if required by the commissioner. Then this is PBM required practices with respect to health insurers. Again, much of this comes from existing law. So this was starts with that language enacted in Act 131, saying a PBM has a fiduciary duty to its health insurer client. That includes a duty to be fair and truthful toward the health insurer, to act in the health insurer's best interests, and to perform its duties with care, skill, prudence, and diligence. And then it talks about in the case of a health plan offered by a health insurer, the health insurer remains responsible for administering the plan in accordance with its contracts and to comply with all applicable provisions of Title VIII and this title. So it doesn't shift. Its responsibility still rests with the health insurer to ensure they're complying with required rules and statutory provisions. It requires a PBM to provide notice to the health insurer that the terms contained in the next subsection may be included in the contract between the PBM and the insurer. And it says a PBM that provides pharmacy benefit management for a health plan must do all of the following: must provide information, all the information that the health insurer requests relating to the provision of benefits to beneficiaries, and all financial and utilization information relating to services to the insurer. There's some confidentiality provisions in here, and disclosure talked about when disclosure can be made in a court filing to state and federal governmental officials when authorized by the Consumer Protection Act, when ordered by a court for good cause, or when ordered by the commissioner. They must notify the insurer in writing of any proposed or ongoing activity, policy, or practice of the PBM that would present any conflict of interest with the requirements of this section. With regard to this dispensation of a substitute prescription drug, we were talking about this earlier, for a prescribed drug to a beneficiary in which the substitute drug costs more than the prescribed drug, and the PBM receives a benefit or payment directly or indirectly, the PBM must disclose to the insurer the cost of both drugs and the benefit or payment that the PBM accrues as a result of the substitution. If the PBM gets any kind of volume-based incentive or payment for sales of certain prescription drugs or classes of, or brands of drugs, they must pass that payment or benefit on in full to the health insurer, must disclose to the insurer all financial terms and arrangements for remuneration of any kind that apply between the PBM and a drug manufacturer that relate to the benefits provided to beneficiaries under or services to the health plan, including formulary management and drug switch programs, educational support, claims processing, and pharmacy network fees. And then again, has confidentiality provisions and the exceptions, same exceptions to the confidentiality provisions. Here's language we talked about earlier. This was new in Act 131. A PBM contract with a health insurer shall not contain any provision purporting to reserve discretion to the PBM to move a drug to a higher tier or remove a drug from its formulary any more frequently than 2 times per year. And then this provision in subsection E which may make sense to take out because it talks about spread pricing, but it says at least annually, the PBM must disclose to the insurer, DFR, the Green Mountain Care Board, and the Office of the Healthcare Advocate the aggregate amount the PBM retained on all claims charged to the insurer for prescriptions filled during the calendar year in excess of what the PBM reimbursed pharmacies. So this is reporting on the spread, which doesn't make a lot of sense if the spread is banned, but if you don't end up banning the spread, you may want to keep some version of this language. And compliance with the requirements of this section is required for PBMs entering into contracts with a health insurer in the state to do pharmacy benefit manager in this state. Subchapter 4 is on PBM relations with pharmacies. So the last section was PBM relations with insurers. Now we're with pharmacies. Again, a lot of this language is the same as existing law. Within 14 days following receipt of a pharmacy claim, the PBM or other entity paying pharmacy claims must do one of the following: pay or reimburse the claim, notify the pharmacy in writing that the claim is contested or denied, and some specifics that must be in that notice, and what information the PBM needs and able to determine liability for the claim. In addition to the prohibited practices earlier in the chapter, a PBM shall not require a pharmacy to pass through any portion of the insured's copayment or patient responsibility to the PBM or other payers. So this is no clawback in this context. For each drug for which the PBM establishes a maximum allowable cost in order to determine the reimbursement rate, the PBM must do several things that are the same as existing law. So make available in a format that is readily accessible and understandable by the pharmacist the actual maximum allowable cost for each drug and the source used to determine that cost, which shall not be dependent upon individual beneficiary identification or benefit stage. They must update the MAC at least once every 7 calendar days. And in order to be subject to MAC, maximum allowable cost, a drug must be widely available for purchase by all pharmacies in this state without limitations from national or regional wholesalers and must not be obsolete or temporarily unavailable. They can't set a MAC for a price that the Vermont pharmacists can't get. Must establish or maintain a reasonable appeals process to allow a dispensing pharmacy provider to contest a listed MAC. Talks about the timing for responding in writing to an appealing pharmacy provider. And then some sort of exceptions to the standard rule there. For a denied appeal, provide the reason for the denial and identify the national drug code and a Vermont licensed wholesaler of an equivalent drug product that pharmacies could use to buy the drug for that at or below the MAC price. For an appeal in which the appealing pharmacy is successful, make the change in the MAC within 30 business days after the redetermination and allow the appealing pharmacist to reverse and rebill the claim. This is a provision that is not an existing law. If a PBM denies a pharmacies or pharmacist's appeal in whole or in part without identifying the national drug code and a licensed wholesaler of an equivalent drug that can be purchased at or below the MAC price, and the reimbursement amount is less than the pharmacy's actual acquisition cost plus a dispensing fee, this would allow the pharmacy or pharmacist to submit a claim to the insurer for the balance, and the insurer must reimburse the pharmacy or pharmacist that amount. Then this is language added in Act 131. A PBM cannot reimburse a pharmacy or pharmacist an amount less than what the PBM would reimburse a PBM affiliate for providing the same services. This is in addition to the existing law, new provision saying the reimbursement amount would be calculated on a per unit basis based on the pharmacy's actual acquisition cost and include a professional dispensing fee that's not less than the professional dispensing fee established in Medicaid by DVA in accordance with federal law. And then some provisions we saw in Act 131 as well, that the PBM cannot place restrictions on a licensed pharmacy in excess of those set forth by the Board of Pharmacy or other state or federal law, or withhold reimbursement on the basis of noncompliance with participation requirements. requires a PBM to provide notice to participating pharmacies before changing the formulary. Then there are a number of provisions relating to 340B covered entities and drugs dispensed in that program. We can go over them in detail if you want, but they're the same as existing law. All right. Then we get to a new section of the bill, section 2. This amends an existing statute on advertising practices in Title 8. This would add PBMs to an existing provision that prohibits companies doing business in the state and insurance agents and brokers from using in connection with the solicitation of health insurance, and this would add or pharmacy benefit management, any advertising copy or advertising practice or any plan of solicitation that is materially misleading or deceptive. And it talks about what it means to be materially misleading or deceptive, and what happens if the commissioner finds that it is materially misleading or deceptive. The commissioner can order a cease and desist, give notice and opportunity for hearing to the affected entity or agent or broker. And then if the commissioner finds after due notice and hearing that, and this would add licensed PBM has violated the cease and desist order, intentionally violated any cease and desist order. And this changes from willfully to intentionally, but that's really just updating language to be consistent with the model penal code. So the commissioner can suspend or revoke the license of the insurer, again, adding PBM, agent, or broker. Section 3 is in the health insurance statutes. This is dealing with retail pharmacies and the filling of prescriptions. So to add a new definition, this was discussed in the House version of, and included in the House version of what became Act 131. So this may look familiar to some of you. Definition of direct solicitation, which is direct contact, including telephone, computer, email, instant messaging, or in-person contact by a PBM or its agent to a beneficiary of a plan offered by an insurer without the beneficiary's consent for the purpose of marketing the pharmacy provider's services. Sorry, I think I said PBM, it's a pharmacy provider. And then later on in here, we have provisions about what a health insurer or PBM shall not do. This would add the copay accumulator language, so the insurer or PBM shall not exclude any amount paid by or on behalf of a covered person, including, again, any third-party payment, financial assistance, discount, coupon, or other reduction when calculating the covered individual's contribution to their deductible or out-of-pocket maximums to the extent permitted under federal law. This would also require a health insurer or PBM to adhere to the definitions of prescription drugs and the requirements and guidance regarding the pharmacy profession established by state and federal law and the Board of Pharmacy, and not establish classifications of or distinctions between prescription drugs, impose penalties on prescription drug claims, attempt to dictate the behavior of pharmacies or pharmacists, or place restrictions on pharmacies or pharmacists that are more restrictive than or inconsistent with state or federal law, or adopted rules or guidance provided by the Board of Pharmacy. And then it says that a pharmacy benefit manager or licensed pharmacy shall not make a direct solicitation to the beneficiary of a plan offered by a health insurer unless one or more of the following applies. Then the beneficiary has given written permission to the supplier or ordering healthcare professional to contact the beneficiary regarding the furnishing of a prescription item that is to be rented or purchased. The supplier has furnished a prescription item to the beneficiary and is contacting the beneficiary to coordinate delivery. Or if the contact relates to the furnishing of a prescription item other than a prescription item already furnished to the beneficiary, the supplier has furnished at least one prescription item to the beneficiary within the 15-month period preceding the date on which the supplier attempts to make the contact. And then finally, this says a health insurer or PBM shall not alter a patient's prescription drug order or the pharmacy chosen by the payment without the patient's consent. Then we move on to wholesale drug distributor
We are going to start
Is
that.
that
Okay.
new, that last one that you mentioned?
Yes. Yes, all of what was in section 3 is new.
Yeah. Alyssa has a quick question.
Just on that E right there, does this mean they can't change anything in the prescription? Like quantity dispensed or anything like that?
It says the insurer or PBM and not altering the order or the pharmacy chosen. So I would read that to be inclusive of quantity, et cetera, if that was the order.
So we're gonna skip section 4 because it is gonna be changed substantially.
Okay, great. Saved me a lot of reading. Thank you. All right, then we get to section 5. The first thing to note here is that because this bill was introduced last year, the date is out of date. But then would repeal the existing provisions in 18 VSA sections 9421 and 9471 to 9474, which are those kind of various provisions on PBMs now, because they're all being subsumed into this new chapter in some way. And then section 6 is applicability. Again, the dates are out of date, but this would say that the provisions of section 1, which is the whole licensure and regulation of PBMs, would apply to a contract or health benefit plan issued, offered, renewed, re-credentialed, amended, or extended on or after a date certain, including any health insurer that performs claims processing or other prescription drug or device services through a third party. And would also give someone doing business in the state as a PBM on or before a date certain 6 months to come into compliance with the provisions of section 1. And then as introduced, the act would have taken effect on July 1st of last year. So another date to update.
Great, so easy, right?
Let's take a vote.
Very impressive. Thank you.
So Jen does have a very good comparison. It is on today's committee page. I think we have Department of Health coming in at 11 for budget. I think people probably want to stand up and move around a little bit. So let's end this here. Before we I'll get with Jen and Claire and try and get Jen scheduled back in to review, what's new before we start taking testimony on this next week, which we will have a lot of testimony on PBMs next week. Great. Thank you so much, Jen.
Sure.